The topic that, well, I don't know, I don't have the slides to show you what Brady set up for the talk, but it's relatively straightforward stuff. I'm going to talk about the interesting times that we're living in still, and that's somewhat of a segue from last year as well, because I'm seeing more and more of interesting times and opportunities. And I'm seeing in those interesting times and opportunities some brilliance and some stuff that makes me insane. And my guess is that's not dissimilar from what you're living through. And what I hope to do is to provide you with some sense of hope and optimism and some ways to see a pathway between where you're living right now and better approximating that hope and optimism of what might happen professionally and for the people that we serve, because that's my desire. My work has centered around changing healthcare delivery in the United States based on the premise that high-performing primary care is the foundation of any effective healthcare system. And the way I've worked on that is to start thinking about just the interaction that I have with the person that's come in to see me and thinking about how to make that really work well. And then what kinds of systems do I need to build around me in a practice that make that function effectively? And then what systems can be built around a practice and practices that help them function efficiently? And that's a trajectory. And that's what Dr. Guthman was just talking about, is sort of that meta structure. And I'm working a lot at the meta structure level because I think that's where a lot of interesting stuff is happening right now. And I think there's a great deal of clarity in this room around what happens at that level of the dyad, the person and the clinician working together. So I'm going to touch on all those things and talk about the interesting times. So the interesting times come from obvious circumstance in that the healthcare cost trajectory is unacceptable to many people, and therefore there's a national imperative, if you will, to change that healthcare cost trajectory, and a desire to do something other than the typical same old prior authorization, denied benefits, increased copay and all that kind of stuff world, although that stuff is still happening. So what I'm going to describe is not perfect. The world we live in is imperfect, so we're going to have a lot of missteps and misapplications, but we'll also have some brilliance in that and some great opportunities. So what I'm seeing right now runs the gamut. I hear about really neat healthcare systems. Like I was talking with Tom. Oh, he's out of the room, so wait, I'll tell you all this like dirty secrets now. But he was telling me that they had this really neat homegrown EMR that they've been using in their system for quite a while that was just incredibly elegant. And with one click, as he's in there in a patient's chart, he could look at the medical evidence behind something, see the notes, and see everything that's going on. I just had this whiz-bang prescribing recommendation engine that would then drive it to the pharmacy. And so he could see these are the right medications and the top choices and the best things you could do for this person right now based on the diagnoses that you're calling up, and it would weave it all together and it would put it in the note. It was terrific. It didn't meet the federal requirements for meaningful use. So now they're on stupid EMR. And it's a big step backward for them. And that's the kind of stuff that makes me crazy, in that the national policy on meaningful use is intended to help clinicians across the country adopt electronic records so that we can deliver better care on a more consistent basis for the people that we serve. But the manifestation after you put that through a political engine is uglier and stupider than some of the brilliance that's out there. And that makes me crazy. It makes me crazy to look at regulations about, the thou shalts and ponying up these data when we know in practice that a lot of this stuff is silly manifestation of checking box to please clerks. And because they're responsive to their masters who said, we're going to have this policy in a program. And that makes me crazy, and I want to bang my head against the wall when I see that stuff. And I know more of that's going to happen. And I know that there are settings right now where to solve the problem for healthcare costs, one of the things that makes me nervous is putting more cost burden on people who may therefore say, no, I don't think I'll go get the healthcare I need. And that worries me. I worry about some of these high deductible plans. I worry about the big out-of-pocket expenses. I worry about that aspect of the Affordable Care Act that says Cadillac plans are going to have a 40% tax to employers. And Cadillac plans are defined by the amount of medical expenditure. And the solution for that that's easy is to say, well, let's just ramp up the deductible. And so people right now who have insurance where they can go in there and get primary care, the kind of stuff that we do, which is what solves the problem, I think we're going to have many people where they're all of a sudden they've got a $5,000 deductible and they say, meh, maybe I'm not. Maybe I'm not going to go in. And that makes me crazy. I can see the policy decisions behind it, and I don't disagree necessarily with the intent, but the manifestation is stupid in some ways. In some ways I get it. There's all this desire to have people understand skin in the game and all that, and you know that I get that to some extent. I'd rather people make better choices about smoking and healthy habits and eating and exercise, and you know, it doesn't cost me anything to get 14 CAT scans a year. Well, yeah, if you think about the radiation, it does, but that's a tough argument sometimes. If you want to glow, you got a nice glow about you. Why don't you get another total body scan? So, you know, so there's stupid incentives and there's stupid things going on, and I want to recognize that, but then I also want to move on and talk about what I'm seeing in some of the brilliance and some of the possibility and tie that into who we are and what we're doing. Some of the brilliance that I'm seeing is inventiveness. We're living in interesting times in that there's a major sea change. There's a tectonic shift in the way money is working in healthcare, and that drives a lot of behavior. And because of that, it's creating some flexibility in the margins that are starting to appear more than marginal in the way that we practice. And you hear about that, some from Dr. Gutham's description of what's happening at Advocate and what Larry Lindemann gets as a check at the end of the year, which is breathtakingly large. Man. So anyway, put that aside. This is like 150% of Medicare plus a big fat 5-figure check. Whoa. All right. So yeah, that's good stuff. Like, let's see more of that around the country. But I'm seeing that. And that's the cool thing. I'm starting to see moves in that direction. I'm starting to see health insurers, maybe for all the wrong reasons, but you know, at the end of the day, I care less about what the reasons are if they're doing the right moves and they're moving in the right direction. But maybe for the wrong reasons, they're saying, we've got to change the way we're paying, and we think primary care is it. Great. I like that. How are you going to do that? The details really matter. Well, we're going to develop this long list of mother may I's from the practice. And if you do all this kind of stuff, we'll throw you a bone. Yeah, you're killing me. You got the right idea, but the manifestations of it are just stupid. And we got to shed that, and we got to go with what's the real point. What really gets the kind of outcomes that matter? It's a lot less about the process. It's a lot more about the outcomes. How do we get to that? How do we track those outcomes? And how can we show, without a heavy lift at the practice, that it's doing really well? So let me describe some of that stuff that I'm seeing. What I'm seeing now is some insurers are saying, you know what, the end game is not all these process indicators that cause pain in the front lines of primary care because of all the work they have to do to prove quality. Really, the end game for the insurance industry is total cost of care and their premium from year to year. That's the problem they're trying to solve. And oh, by the way, they've got to show that the quality stuff is okay, which is a sideshow. That's not the main game. The main game is total cost of care. So how do they get there? So as they start to get that and realize that, then they realize, well, they've got the data on total cost of care. It's claims. They see that every day, all day. They've got that data, and they can risk adjust it and do all sorts of stuff. And I'm seeing some insurers now say, you know what? I can see total cost of care. You don't need to prove that to me. As a matter of fact, I wouldn't believe it if you tried. I've got the data. We'll look at a risk-adjusted basis. Doing pretty well. Better than expected. Here's a check. Well, they've got to do some quality stuff too, and they're not going to give that up because it would look bad, and it might be bad. You know, it can't just be about chopping down costs, because you can see 10 evil ways to get there. So they're being held to a standard of show that there's some good quality. The interesting thing I'm beginning to see with some insurers is that they're realizing we can get a proxy for quality out of claims and absolve the practices of proving quality to us. Now, they have to look at proxies, and it's a little bit weird. And as you look at these indicators they're using, they're kind of value indicators because they're efficiency plus quality. For instance, ambulatory care sensitive admissions. That's an interesting marker. It's an interesting proxy for quality, because you could posit, as I would, that effective primary care produces fewer unnecessary admissions to the hospital, and especially those admissions defined as in ambulatory care sensitive conditions. Things like asthma, hypertension, diabetes, pneumonia. If we had a highly effective primary care system, there's pretty good evidence that those things would happen less often. And so some of these insurers are now saying, I buy that. And so we can use a proxy quality set of potentially preventable hospitalizations, emergency room visits, readmissions, complications in the hospital, and potentially preventable services. So that's what Wellmark Blue Cross and Blue Shield in Iowa and South Dakota has bought. And that's their quality indicator now. Not that, it's a bunch of stuff. So they have a whole bevy of indicators. They're pulling out of claims, and they're turning to the primary care practices in those states and saying, don't worry about it, we got it measured. They've done the prove it with registries and show us all that kind of stuff. And what they've recognized is that's a lot of work of doing that interface. Now, I'm not saying disparaging registry. What I'm saying is that's not the proof of the concept. That may be the tool for the work. We may need that in our practice to be effective. But at all this interface and ponying up this data and show all this stuff to insurers, like, all that extra work? No. And because they know without a doubt that they've done that for years. They've written big checks to docs based on how well you did on the registry stuff. And what they found out at the end of years of doing this was it didn't pay off on total cost of care. It didn't. So you can be great on a registry and completely lame on total cost of care. And remember what their end game is. Total cost of care. You got to get there. If you don't get there, it's not going to work. So these guys get that. They recognize that disease management alone is insufficient. They see that they can measure total cost of care and get proxies out of claims. And now they're putting tens of millions of dollars on the table for the primary care practices every year based on how you're doing. Because we can score you off of claims. So we can say, here's a ramped reimbursement reward system based on that kind of stuff. And we can put extra money in the pot for primary care. And we've got another state, can't mention because it's not public yet, where they said, well, let's take $50 million next year and put that out to primary care because we want to create a counterbalance to this ACO thing that's driving all these primary care guys to say, I got to sell out and be bought by a hospital. Or either actually bought out by a hospital or aligned in some way that's just driving ACO that looks good on paper, but it's just a replication of the same old thing, which is some of what we fear in this room, and rightly so, we should, because I think aside from the advocates and a few other brilliant examples, there are probably a whole lot of stupid examples out there that look great on paper, but are really just replicating the current reality and holding on to the status quo. And I can't stand that, I think, any more than you guys can. So I'm seeing some brilliance. I'm seeing lots of states that are beginning to think about this. Programs in Colorado with Medicaid that are starting to put a toe in the water, put $20 per person per month on the table for these regional care coordination organizations that within Medicare they can organize these health coaches and outreach workers and do this kind of stuff on behalf of people that the practices and the groups identify as being at risk. And, it's a start. It's a good move. It started with a premise that I buy that I think is really good. Let's put some extra money on the table for primary care to deliver on the promise of who we are and what we do. And it does not force you to sell your practice to a hospital. It does not force you to join a vertically integrated organization, except that the states carved up these regions and we can work together. So the fear expressed in this room, which I think is completely legitimate, is that this organizational structure could swamp any potential savings and could be just as stupid as the current reality and add expense to the system. Absolutely legitimate. And so the way through that then is to think, just as you have in your practices, what's the real goal and where are we being forced to sign up to a form that misses the goal, that misses the point, as opposed to the function that gets us to the goal and gets us to the point. That's what you guys have clarity to in your practices and why you would even show up and be here in this room. And that's what we as a group can do, is because we have that clarity. So let me describe what those functions are at core, and you think about them in your practice, and then we think at a group. So I'm going to describe this in the context of that dyad of interaction at a practice level, at a group level, and at a system level, and to think about that clarity and how to weave that together. Because I'm blown away by the concepts of what's happening in this room with people doing just amazing experimentation at all of those levels and the potential of doing that across the country. And that's why I'm hopeful and excited about what's happening right now. So, at its core, primary care is the core of a high-functioning system. The definition of primary care from World Health Organization and Barbara Starfield's work at Hopkins for decades is first point of access, person-focused relationship over time, care that is coordinated across these stovepipes of a non-system, and comprehensive services as opposed to narrow and specialty-based organ system services. That's what defines primary care, and when we do that well, outcomes are better. So just primary care per se at a population level decompresses costs and improves outcomes. Good primary care outperforms usual primary care and certainly outperforms bad primary care. My work has been about what is it that makes it possible to reliably and consistently deliver good primary care? And the answer to the question I'm working on right now is payment and measurement policy. That's the gap between us. And then figuring out how to organize that stuff. So what do IMPs have? IMPs have clarity to, I want to shed the junk and work on the real stuff. And the real stuff is engagement, relationship, which right away calls into question access, because how good can your relationship be when people can't get to you in a timely manner? One thing that's brilliant about small practices is, and by the way, I mean this in the context of small practice working solo or alone and small practice working in the context of an organization. To me, they are not different. It's the concept that in a small practice, when there's a problem with access, you know it and you feel it. And you probably feel guilty about it, and if you don't, you should. And so you act on it. And when I'm part of a big practice and I see there's an access problem, matter of fact, I often don't see that, and that's a problem. Run by the waiting room because there's a whole crew of people out there and I don't really know them, they don't know me, and I feel guilty because they're probably waiting for me, but maybe not. I just know I have the next room to get into and the next claim to sign. So that's the difference. In a small practice, somebody's in the waiting room, it's like, that's on me. And I got to do that kind of stuff. So access and relationship. And then you start to think about coordinating care and providing comprehensive services. As you think about that, those are manifest. They're evident in the moment-to-moment work that we do. The brilliance of small practices is that those parts are not hidden. They are obvious. Small practices have that advantage. We can do that well or badly. We can build systems that mistakenly get in the way of those attributes, but it's less likely in small practices. Now, whether or not we choose to use that practice as an engine to pursue quality and excellence is up to us. But when we do, the turnaround is fast and the outcomes are breathtaking. And we showed that in the Ideal Medical Practices Project when we applied a simple health coach non-clinical overlay to practices that chose to participate in this work. And we're able to identify individuals who were seeking care around chronic disease who struggled with stuff, and this health coach could help them with that on your say-so, and then help bring them back to you having learned a new skill set called problem solving, and the outcomes were terrific. So we know that solo and small practice can do that. We know that the overlay of team could be really simple. And it didn't have to be some big, huge, expensive thing with, where you have to hire all these staff. That's a mistake between the form and the function. The function is people working together on behalf of the patient population, but never giving up on person-focused relationship over time, access, coordination, and comprehensive services. The Ideal Medical Practice Project worked because we put on an overlay that added to the comprehensiveness of service around people who struggled with self-efficacy in chronic disease management. And so that was a simple intervention, and it was effective, and we published that, and the results are terrific. Don't ever if you want to, stand up, and anytime somebody says small practices can't do that, and say, excuse me, stop. Not true. Absolutely, positively can do that. When the definition of that are the real outcomes and not a checklist of manifestations that are designed for and by huge organizations. When the checklists are, you got to have a diabetes nurse educator, no. The checklist should say, you do really good diabetes education. How you get there is on you. Getting there is on you as well. But we keep making that mistake. Not us. They. Evil they keep making the mistake. But we don't make that mistake. If you know what you're doing, and if you can see it, and they can see your own gaps, then you have an opportunity to act on it. And it's not that hard. The manifestations in 33 measures for CMS around ACO are all these details and focusing on all this work you have to do to pony up results to them. And it's all this minutiae and detail and kind of misses the fundamental point. It misses the core point of what is effective primary care. The manifestations of NCQA, PCMH is a lot of detail. And it doesn't necessarily add up. You can check all the boxes off and you can still miss the core attributes of effective primary care. Now, on the other hand, you could also learn some self-reflection in practice. So it's not per se a bad thing unless it's distracting you. So, you know, I don't have a beef with it on that level, but I suspect it's distracting a lot of people where they're chasing the process that doesn't necessarily lead to the outcomes. Then I got a beef with it. Then I say it's dumb. You're letting shiny objects distract you from what really matters, and we shouldn't let that happen. I know you guys are not letting that happen, and I'm glad to see in some parts of the country some insurers are saying that's not the ticket because we don't think that's going to necessarily get us to the goal. The goal for them, total cost of care, and make sure you at least cross the threshold on quality so we can show to the employers and the government and all those guys that we're not doing this at the expense of quality. So let me describe a simple way then. What I described was how an insurer can assess on their own data cost and quality, and that's good enough for them. But it's not good enough for what you need to do in your practice to close the gaps and know what's really going on. You have to have your finger on the pulse of what's really happening for the people that you serve. And to do that, you need some kind of engine and information set that's going to feed you. I had a good conversation with Rip Hollister last night, and we were talking about registry, and I was initially thinking, registry, pile of junk, who wants to get there? Why even use the darn thing? But I was thinking about it in the context of forced reporting to health plans. And in that context, I don't think it has a lot of value. And he posits, I'm putting words in his mouth, but you can stand up and holler at me if I get it wrong, is that registry is a key vehicle for understanding when people have needs that are unmet, and to be able to act on those expeditiously, and not just when they're showing up in the practice, but to be able to run reports and find people who you've got a relationship with but have been lost to follow-up, and you need to reach out to them and say, hey, come on, what about X, Y, and Z? I think that's good. So registry, I think one of the big problems right now is a mistaken understanding of what tools are effective for what job. There's an absolute need for having engines in our practice to identify gaps in care. The only beef I'd have with registry is that it's only focusing on a narrow spectrum of need. And I want to see registry focus on a much bigger spectrum of need, because the big indicator for probability of bad stuff happening for people is around self-efficacy. There's really, really good data on that. So I need an engine that doesn't just identify the hemoglobin A1C, the systolic and diastolic blood pressure, the lipid level, the last time it was tested. That's not enough. That's good stuff, but I need to know, does this person have the confidence to manage their condition? Because that's telling me act or not act. Actually, it's in the context of the other things as well. Yeah?
Gordon, I don't hear anyone talk about this stuff outside of the IMP world. Maybe I'm not listening to the right people or finding the right people, but how do you, for the last 5 years, the only time I hear about this type of stuff that anyone talks about self-efficacy in terms of predicting patient outcome is in this world. Can you talk to us about
yeah,
on the national stage and how to bring that conversation maybe?
So yeah, for the recording, I'll just reiterate that. Emily's asking the question about how do you bring the conversation around self-efficacy as a cornerstone metric for measuring quality within the practice.
I think particularly when we're thinking about healthcare reform, is finding very
Yeah.
good in ACOs and health.
So there's two things. And this is the risk, is that implicit in the question is using that as a metric of valuation of the practice for an insurer. And I would uncouple that. I would say that's a measure we need in practice to understand how am I doing for this person now and what work do I need to do for them at a dyad level, but also at a population level as you think about working in collaboration with others where you can maintain independence and yet begin to bring at economies of scale support that makes it easy to be brilliant. So I think it's very important at that level. I could care less about reporting to them on that metric. I think they should focus on their outcomes, total cost of care, and a good enough proxy off of claims. End of story. Done. Stop nickel and diming me. You're killing me with minutia. Not you, those guys. They're killing me with minutia. Push that aside. The cool thing is I'm beginning to see that in some settings, in some really forward-thinking advanced insurers like Wellmark Blue Cross and Blue Shield. As an example, they've taken that step. There's another state that's looking like it's likely to take that step. A lot of them are afraid to give this stuff up because there's a lot of investment in that. We've always done it this way, and so it's going to take some time. But what's going to change it is that there's a dawning recognition that that old way of valuing quality doesn't play in a big picture. It's expensive, and it's focusing on too much minutia, and it's making practices crazy, and it's not necessary. Now, on the other hand, back to the practice and how to do that, we do need that kind of stuff. There's a wealth of evidence around that. There are people like Judith Hibbard from OSHU in Portland, Oregon, who's talked about patient activation, and there's decades of research on self-efficacy. There's a lot of evidence behind this stuff. So that's no surprise. But I'm going to jump to questions in just a second. Let me just finish the thought around how it is we measure and value at that dyad and how we begin to think about creating systems. So right now, the engine that we used in the Ideal Medical Practices project was John Watson's How's Your Health engine. And that's this behemoth of a health risk assessment tool. Absolute behemoth, huge, 120 question branching logic survey that you have to use online. And it works well in English. And I worry that it doesn't really translate culturally if you start using it in Spanish. So it has all sorts of limitations. But in that narrow context, which may be a lot of your practice or very little, it's brilliant because it begins to assess all of these things and begins to assess things like the ultimate scoring of access. To me, if you're a advanced medical home in our context, the scoring is them, your patients, telling you what they think of your access. In a developmentally early stage practice that's just getting going with this stuff, they may measure things like appointment delays. They may then advance to measuring things like secret shoppers calling up to say, can you really get in? The end of the game is, I don't care what office hours you have, whether you're open nights or weekends, I could care less. For an immature practice, that may be their pathway, but the ultimate goal is your patients say they can access you whenever and however they need to, and access is not an issue. When you've done that, you are in the promised land of access. You've done it. And if you've done it at the expense of continuity, you and they are going to suffer. That's not good. So it's all of that kind of stuff built in. That's a measure set that, to me, just rings out. Nationally, I am working nationally to get a patient experience measure set as the way we understand quality in primary care. Because right now, if you look at the ACO 33 from CMS, that's a fraction of what we do in primary care. The good news is there are really smart people in Washington who are testifying to Congress to say, guys, this is dumb. You're measuring fractional little things that do not aggregate to primary care, and we're missing the good stuff. Read Bob Berenson's testimony to the congressional committees. It's just brilliant. It's like you're barking up the wrong tree here, guys. This is the wrong stuff. He was on MedPAC, so he's a very important guy and gets this kind of stuff. Talking to people like Shannon Brownlee, who are just brilliant people. So there's a good opportunity to have this discussion. I'll work on that kind of stuff. What you guys work on then is, how do you know? Watson's engine's out there. It's for engines like that, it's cheaper in dirt. It's weird thinking about how to use it, but we did that in the Ideal Medical Practices project. We have all these tools. How do you use this crazy thing? And why would you use it? And what do you get for it? If you've got the context of, I'm working in an environment where we have this potential reward for being brilliant in primary care, man, that's the engine I'd use, because that tells me right away what's going on for that person, and it rolls up to the practice level to see how am I doing overall. And I can use that engine for self-assessment, which is why we as a group have chosen to create this self-assessment recognition program, just so you can understand how do you use this to self-reflect. And if you guys want to work together on this kind of thing, we're going to try to get this to count for like one of those module part 4 things for what do you call it? Maintenance and certification. So we've got that in our trajectory and plan, and we've sort of built some beta on that. It's done. It's done. So Lin Ho did this. So part 4 of the maintenance and certification. Now we've got a way to do that through use of this. The aggregation I'm going to touch on, then I want to go to Q&A with you guys. The aggregation, and let me know what if we've got. Where's John Brady? No, there he is. So timing, you let me know.
You got about 4 minutes.
Okay, good. So
12.
So the ACO thing, I want to step it up to then talk about how we begin to aggregate. One of the problems that's absolutely obvious is that solo independent practices get the dregs when you start talking with insurers. You get whatever contract they put in front of you, and whether or not they love you, they do not have the time to deal with you. They have limited resources that they want to apply to network management, which is what they call interface with you. And you are the smallest of the small fry, and they don't have the time. They're going to go to the one guy with 4,000 PCPs and sign that contract, and they're going to spend a lot of time and money on that. And you're going to get boilerplate, sign it or not, I love you, but sorry, tough. So the solution to that is aggregation. And that, in this room, I'm wearing Kevlar. No, I think there's a way forward. And when I hear Jeff Hootery talk about what he wants to do in Michigan, that just rings like perfect crystal. That's like, that is really good. The idea that we can create that aggregation within a contractual unit, aka state, and figure out how to aggregate with others and build that infrastructure that helps practices be brilliant, which includes our brethren who are not in this room and doing this kind of stuff, but would be philosophically aligned if we can get past years of cynicism and burnout, and who may be in big behemoth practices with all sorts of staff, and we're not going to bad talk them or anything about saying you got too much staff and overhead, dude, you're killing yourself. No, they'll figure it out over time, but you can go to them and say, work with us, because we're going to help you be brilliant, not because you have to change anything. If you choose to go there, fine. But because we're going to bring to you some of the simple population health overlay that we learned in this project, and together we all win. And if you choose to lean up over time, I'm there for you. We'll talk. We'll help each other out. And I'm starting to hear from the insurers, they would love to see some counterbalance to the everybody gets sucked up by the big university hospital system and then made to toe the line and buy into this big pipeline that just adds overhead, which we know is a deadly pathway, unless you're advocate. So, you know, there's interest out there. We have to show the way. They're not coming to us asking for this. We're too small. That's what we hear all the time. The only solution right now is aggregation. So look to Jeff, communicate with him on the forum. We're going to do this in the forum and less on the listserv. We're trying to push things in there because we want to have that conversation and support each other. Because the goal of us is to make it not just possible to have a solo independent practice, but to make it brilliant and to make it just so cool, not just for the patients who are coming to us, because believe me, there's really good evidence patients would rather go to small practices. Ease of access, drive right up, know the person, they know me, hands down win in the eyes of the public. I think they are our biggest advocates in this kind of thing, and we need to couple with them and work with them so that they can help articulate the need and urgency for our survival and growth over time. and swing the pendulum back from the everybody's getting bought out by hospital systems, which has got a limited time frame before everybody wakes up with this huge hangover and massive indigestion. It's like, that was a really bad idea. As you wake up and look across the bed and say, oh, did I do that? There's going to be a lot of that going on. Yeah, so believe me, yes, it's crude, I admit it, but it happened in the 90s. I saw that. Hospital systems, we got to buy up primary care. And then I was there when they woke up. It was like, wow, I got to get checked. So the opportunity is there. It's going to be, because we're small and independent, we're brilliant and we're hamstrung, because this is going to come at the cost of everybody just tightening the belt and working harder to do this stuff. And that is a really sucky strategy. So what we've got to do is to go to people like Jeff, who's got this enterprise level concept, and say, Jeff, I want you to win. I'm in New Mexico and you're so far away from me, but if you win, I can maybe figure it out and take the ideas and bring it down here. That's the way forward. When you start hearing about what PJ's doing in Colorado with a refugee program and Medicaid, it's like, you're like ringing the bell on that population? You're kidding me. How are you doing that? So we're going to do a brain suck on PJ and call him up and harass him until we get every ounce of what he's doing out of that, and share that in the forum, on the IMP Center. Not so much on the listserv, because we're trying to pull it in there, and we'll come back to that. So that's where we're going. The potential is huge, and you heard Guthman talk about that. His and my shared vision is primary care ACO that maintains the independent and the small practices. Even if you're not necessarily independent and you're part of a larger organization, and that's done well, I have no problem with that, and I think that's brilliant. As we think about how do we build that joint infrastructure and not overbuild it and blow the thing up? How do we not become the man that we left and maintain that coolness and that interaction? I want it all, and I think you do too, and I'm confident that we can get there, although it's going to be hard. So, questions?
You mentioned challenges for us are total cost of care and ultimately self-efficacy in our patients, which often is dependent on their cost of care.
Yep.
How do we get that data to help?
Okay, so we've got, so what ails people as they work towards self-efficacy? And there's really good evidence around that, and there are multiple factors. Evans and Stoddard has a really nice model on health and wellness and the drivers. And so we have things like prosperity, which is a key driver, huge driver of outcomes in terms of health and wellness. And we have very little impact on that. We can make some marginal choices about $4 prescription, $400 prescription, but those are marginal choices. Most of that stuff is out of our reach. But it's still there, so we got to own that fact. We have things like the way we design healthcare. A lot of that's on us. We have marginal impact right now on things like that the orthopedist decides to do a procedure in an inpatient setting where they're going to tag on a facility or campus fee in addition. Well, you know what? Next time, dude, I might refer to somebody else. Or maybe I'm in an environment I don't have a somebody else. So, you know what? I'm going to learn some more orthopedics and do some more, I'm trying not to send so many. When they do, it's like I'm going to sweat every time. The point is that on the margin, as we start to look at these multiple factors determining health and wellness, family and social dynamics, prosperity, health and wellness, behavior choices, there are a lot of complex things. The good news is that we can act on some of those and have marginal improvement at the person and population level, that even though you have only a bit of control over all of this, it aggregates to something really noticeable. I'm not as nervous about the short and long-term trajectory of this. The short-term trajectory, I'm nervous about when I see systems building basically disease management all over again, and that did not solve the problem. It's a nice thing, but it didn't solve the problem. I think we have the brilliance because we have those 4 cardinal attributes of primary care solved, and we have the long term too. So Guthman was saying, we can solve this thing now, but I'm worried 5 years down the road. Well, I'm not worried 5 years down the road, because look at the UK PDS study of diabetes. When do you start to see macrovascular complication drop if you have tight glycemic control? 9 years out. 9 years! It's like, I want to plant those seeds now, because I want to reap those rewards 9 years. The heck with a 3-year contract, I want a 10-year contract. I want to lock these rates in there. I want to get the results downstream. And I need a big enough pool that we're going to be able to get that. And it's like, I'm going to ring that bell. It's going to be great. I love that. I want to see that long term. So how do you get there? How do you understand that with patients? Is that part of what you're asking?
Well, my biggest challenges in my practice are the patients who have disease, who don't have the resources to manage it. They're the biggest cost to the system. They're the ones that come back. She's the lady who has an A1C of 9 to 11, has had multiple amputations. She can't afford her insulin.
Yep.
So I spend most of our visit getting her insulin. But how's your health is only cursory
Yep.
cost of care, because so many patients over the last 5 years have come in, and I reach a certain point with them, and then they disappear. And I have a feeling that their cost of care that I'm driving to help them be healthier, they've made a decision based on cost. They're gone.
Yep.
And then you mentioned that the insurers, their whole bullet point is total cost of care. But yet I don't have access to those 2 data points to make.
Yeah, so you can, as you set up these relationships, as a relationship you set up at an enterprise level for an attributed population in this, that quid pro quo is we need the data so that we can understand who those individuals are, so that we can segment them, not just on the How's Your Health stuff, which is a terrific segmentation engine because you can identify people in strata from their responses there, but we need this information from the plan as well, because the claims tell us about all the experience when an individual touches the healthcare system, because the healthcare system is really, really good at generating a claim to get the money to flow. So that's a terrific engine for understanding where things are happening and segment people. On the margin, when you talk about people where they have breathtaking problems from finance and all that, some you can solve, some you can't. What happens overall at the population level is you get, in aggregate, a little bit better choice over time, and it accrues to the whole population. That doesn't mean any one individual is mutable. That there'll be individuals you can identify where you can do everything in the world and it's not going to change their outcomes. But there are other individuals where it will, and so that's where, on the margin, it's going to succeed over time if you do these things.
And then if you work on the margin, it succeeds. Jeff had the idea that what you want to identify is the radiologist who had a group in our town that was doing $600 MRIs, $700 CT scans, who just got bought out by the hospital. Now I can't find a CT scan less than $3,000. So do we need to be working at those procedures and cornering the market and actually putting that in our communities?
So down the road, as you think about how to step into this, my recommendation is, just like Advocate got into the whole ACO world because they had infrastructure to support it and it was an easy step, you start with what's simple and easy. One of the lessons of the ideal medical practices is that don't buy expense until the demand drives it. So for instance, I heard from PJ yesterday as he was talking about setting up his practice, he thought he should have an MA, and he realized after doing it for a bit, I should have hired the MA when the demand for an MA made it obvious that I had to have an MA. So that's the same kind of thing. So when you hear Jeff talking about the lab thing, he's got a mature practice that's doing really cool stuff, and he's saying, at this point, I think I can step into lab as a disruptive innovation in our community and do some really cool stuff. In the future, he may say, now I'm going to do imaging. Now I'm going to do that. So let the maturation get you there. I wouldn't lead with that. That's an infrastructure, capital expensive lead. So get there when you're ready. Do basic primary care stuff. And when the local environment dictates that you can take that step up, I think it's brilliant. I've heard of primary care plays where they're putting in dispensing engines with robots. You need 40,000 lives to make that work. and they have to be in a geographically tight region so it works in urban centers. You know, let the local circumstance dictate. I think we're out of question time and we're moving on. Yes. So thank you so much.